All right.
It's already
Here we
recorded,
go.
right?
Woohoo. All right.
So Dr. Booth, it's already
Yep.
recorded?
Yeah, I'm starting recording just now.
No. We don't have any pre-recorded for those.
No pre-record. This is all live. A lot of times there are lectures that are a little bit more in depth that I want to give you guys a chance to ask a couple questions in person and also to change it up so you're not just staring at a blank screen with no human interaction. So unless that's how you roll and that's what you want. But okay, so we're gonna get into heart anatomy. So heart anatomy, we have two technical, so even though we're all one unit, we have two technical circuits here. So we have the pulmonary circuit, and its job is just to bring blood from the body to the lungs to get oxygenated, goes through the lungs, and then it gets pumped out to the rest of the body. The blood itself gets received from the atrium. Okay, so this is the pulmonary circuit. So pulmonary, if you saw a question on this, remember the pulmonary circuit, until it hits those lungs, guess what? Even though it's an artery, it's still going to have no oxygen in there, or very little oxygen in there. So this blue blood is...
Are you showing something different than the first slide? Because I can only see where it says 18.1 heart
That's
anatomy.
frozen.
Is that the same for everyone else?
Yeah.
Oh, weird.
Sorry to be the one to interrupt you.
No, it's all good. So no one can see anything, huh?
Just the intro page.
Okay, that's hold on. See, now you guys wonder why on the things I get really confused. Like, am I actually rolling or not? All right, let's try that again. That is so strange. Okay, can you guys see me now?
We can see you and everybody else.
Yes.
Yes, we can see you.
Okay. Can you see this?
Yes.
Yes.
Can you see it if I go like that?
Yes.
Yes.
Okay, so a lot of you guys pointed out that in the videos it's really small. Unfortunately, I don't know what blip there is, but it is a blip where if I go into full screen, it doesn't want to register that I'm on a PowerPoint. So unfortunately, this is going to have to be small, but what I'll do is I'm going to try to make this as big as... Oh, that's not working. I'm going to try to make this as big as humanly possible. Can anyone see that on their screens, or is it like looking at the smallest thing on earth?
No, we can see, if you like put all of the people like way over to the side, then it's really big on the screen.
Okay,
If anyone
perfect.
wants to
And
try that.
I'm going to leave this as is, otherwise you guys won't be able to see it. Okay, so we'll start. Okay, we're going backwards. All right, so pulmonary circuit, we've got to remember, is the lungs only. So you see this person out here, they have used up all their oxygen in their body. Oxygen is going through the vena cavas to the heart, so it's coming from veins. Veins bring blood from the body to the heart. Hint, hint, nudge, nudge. There will always be a question on boards, on my quiz, on my tests about difference between veins and arteries. So these veins, even though it's going up towards the heart, it's still vein. Okay, so veins are bringing the body used up some oxygen, it needs some more. It's bringing it to the heart. This is still the pulmonary circuit. Pulmonary circuit goes from the inferior vena cava and the superior vena cava, which are the major big veins in the body. So we'll go into the next lecture about the different types of veins, but these are the two ones that I want you guys to remember right now. It's going to drop off this deoxygenated blood, this blue blood, not Game of Thrones. Is Game of Thrones the one who bleeds blue blood? I don't remember. But this blue blood is going to come in here and drop off into the right atrium. This venous system, this pulmonary circuit here, is a low pressure circuit. Okay, so just remember, venous pressure is low. So it's going to bring blood in the pulmonary circuit, drop it into into the right atrium. It's going to go through a little valve that we'll talk about soon. It gets put into the right ventricle, and the right ventricle is going to do a really strong push and get this blood out of the pulmonary arteries. So remember, veins bring blood to the heart, arteries bring blood away from the heart. But what's really different about this one is that this artery doesn't have oxygenated blood. This pulmonary artery has no oxygenated blood. I'm saying that a few more times because you're gonna have to remember it. Pulmonary artery has no oxygenated blood. because it hasn't gone to the lungs yet. So how on earth did it get the oxygen yet? It hasn't. So it's going to go into the pulmonary circuit. It's going to come out. Once it gets its oxygen, the lungs, you'll learn about next week, are going to do some magic and have oxygen put in the blood. And now we're in the systemic circulation. So systemic circulation, we're going to bring the capillary, so we're going to go out to the systemic circulation. So we're going to go out through the pulmonary veins, which bring blood to the heart. It's going to go through the left atrium, down into left ventricle. I asked a question on the pre-class questions about why do you think the left side of the heart is thicker than the right side, which you can see in this picture. And what that's going to do is that's going to, the reason why it is because there's so much pressure. More pressure means thicker muscles are needed to push things. So it's going through this left ventricle, out the aorta, and to the rest of the body. So up here is pulmonary circuit. So when it's dealing with the lungs, it's pulmonary circuit. When it's dealing with the rest of the body, systemic. We have 4 chambers of the heart. We have the right atrium and left atrium, right ventricle, left ventricle. Okay. Any questions on that? Okay, moving right along. So if you went to the doctor at all recently, they might have put a stethoscope up to your chest and take a listen to your heart. The heart is located in the mediastinum, which means the mediastinum is a chest cavity. The borders of the heart are at the second rib. The diaphragm, which we'll learn about next week, but the diaphragm is a specialized muscle that helps us breathe. It is divided by the sternum. The sternum is in the front. And then we have the apex down here. So when doctors are having their stethoscope to listen to your heart sounds, they're going to look at the second intercostal spaces, and then to interspace number 5 to hear your heart. You'll be able to hear different things. If this was in person, you guys would have been listening to hearts and all that jazz, but that is not occurring. Okay, the heart itself needs to be protected. And I'm not talking about any woo sensitive stuff. We're talking about real protection here. So pericardium is the covering of the heart. It has 2 walls that surround the heart. So it has 2 layers, 2 layers that surround the heart itself. We have the fibrous pericardium, which its function is to protect and anchor the heart to the surrounding structures. The heart can overfill if it wasn't for this fibrous pericardium. If the heart overfills, guess what? It's not an effective pump if it can't keep up with its supply. And then we have the serous pericardium. Serous means that it's closer to the heart, okay? Serous layer has 2 layers there. They have the parietal layer, which is technically almost the same exact thing as the fibrous pericardium. And then we have the visceral layer, which is the external surface of the heart. That is known as the epicardium. And then because this is a muscle, because it's in a space, what do we need in that space? So if we have a pericardial cavity, do you think we need air, or do you think we need fluid? Anyone?
Fluid?
Yay. Okay. One person. Yeah. Fluid. Okay. Fluid. And the reason why I have fluid in there is to decrease friction. There's a condition of pericarditis, which is when the fluid inside that sac can either leak out or get inflamed. And then what ends up happening is you have a lot of friction of the pericardium going against the heart, makes it really hard for the heart to beat in a proper fashion or even contract in a proper fashion. Okay, the heart itself has 3 layers. Let me just make sure that, here. Heart itself has 3 layers with the epicardium, which is the outside of the heart. Anytime you see a cross section of the heart, that's going to be the myocardium that you're taking a look at. And then just like with everything else, there's always layers to it. Like the skin has its layers, the heart has its layers. The inside of the heart chambers are lined by endocardium. And then the cardiac skeleton itself is what makes up the myocardium. And the muscle of the heart is very different from any other muscle in the body because it has a specific skeleton, and it's designed to kind of go beep and then push, beep and then push, because the whole idea is that it's a pump. We needed to get blood outside of the heart. So this is what it looks like. So we have these little bundles here, and their job is it beats as one. So it contracts, squeeze out, comes down to the ventricles, contracts, pushes, and out. Sorry, I thought that was my child again. Almost got through a whole lecture without my child there. Sorry. Okay, So now we're going to take a look at the gross anatomy of the heart. Okay, so if we imagine over here, that's that little schematic of the circulation there, of the pulmonary circuit versus systemic circuit. We're looking over here, and we have the pulmonary trunk, and the pulmonary trunk is over here, sorry. The superior vena cava, we have the superior vena cava, which is draining the upper parts of the body into the heart to get oxygen. We have the inferior vena cava, which is coming from below the diaphragm, so anywhere below the diaphragm, which means feet, legs, and upward into the heart. It dumps into this place called the right atrium. This right atrium right here, see this little shiny area right here? That is the endocardium. That is the inner lining of the heart itself. Okay, we have a couple of landmarks that you guys are responsible for. One is the fossa ovalis, which when we were developing as in utero, this area was open because when in utero, we don't need oxygen when we're in utero. We have the amniotic fluid from the mom to help us as babies or as fetuses get oxygen around our body. So this hole here was open, and this allowed free exchange just to keep going because this area didn't need to be used yet, okay? Then we have the first valve that we're going to run into. So in the heart, there are 4 valves. 1, 2, 3, 4, 4 valves. This is the first one. This is on the right side, and it's the tricuspid valve. It has 3 little leaflets that you'll see on your lab. It has 3 leaflets, and what they do is that with the right amount of blood, so blood is going to come in here, it's going to create pressure. If you guys get the David Bowie song stuck in your head, perfect. That means I've done my job right this week. But tons of blood is going to pull up here. There's going to be enough pressure to push this valve open. So the tricuspid valve is going to open. Tricuspid valve, you see these little spider web looking things. These are called chordae tendineae. And their job is to tether this valve. So it's not just flapping in the breeze waiting for anything to happen. Okay, so we have this little tether. And the tether comes to what's known as papillary muscles, and the papillary muscles can actually contract and pull on those leaflets as well. Okay, so we're now going from the right atrium into this right ventricle. There's little pink area that kind of looks like, I hate to say it if anyone's a vegetarian, but it kind of looks like meat. This right here is the myocardium. Okay, and the shiny area is the endocardium. So now enough blood has come out here. The blood is pooling. When enough pressure is present and enough, so it's kind of like trying to, if you ever took a little hose or a little clear hose and you put some water in and try to make the levels equal, you would notice that when you put enough water, it's going to shoot out the other end. So that's the kind of same idea. So we're putting some blood in here. We're building pressure, enough pressure to open the pulmonic valve, which is has 3 little cusps that hang out here. And then it goes out to the left pulmonary artery into the lungs to get oxygenated. Lots of happy jazz is happening out here. It comes in through the left pulmonary vein. And the difference here is that the left pulmonary artery, even though it's an artery and it's taking blood away from the heart, it has not been oxygenated yet. So the left pulmonary artery is the only artery that does not have any oxygen in the body at all. Okay, so that's a very important point to make because that is a very important board question, to be honest. Okay, so then it's gone to the heart, and then here's the other jazz here. Left pulmonary vein. Veins are supposed to have deoxygenated blood, but it's coming from the lungs. We need to get it into the heart. The left pulmonary vein is the only vein that's going to have oxygen in it. Okay, and keep in mind that the right and the left have to come the different ways. There's actually 4 sets of pulmonary veins here. Okay, so we're going into the left atrium, which is a little bit bigger because it's accommodating for having to go against the pressure of the rest of the body. Okay, it's going to have volume that's going to build up. Pressure is going to build up. It's going to cause this bicuspid, also known as mitral valve, to open. So the big differences between the tricuspid and the bicuspid is that the tricuspid is on the right side of the heart, and it has 3 leaflets. Bicuspid, it's kind of telling you about what's already in there. Our mitral valve has 2 leaflets. It's just how we were developed in utero. And it's on the left side of the heart. So enough pressure is going to come here. Enough pressure is going to come here. It's going to open up this mitral valve. and then it's going to go into the left ventricle. Left ventricle has a very thick wall because it has a lot of pressure to go to. The venous side has about maybe 50 millimeters of mercury of pressure to go into. The left side of the body has about 120 millimeters of pressure to go into. Okay, so big difference there. That's why it needs to be stronger, it needs to be bigger, it needs to be thicker, it needs to be like the He-Man or She-Ra of all muscles here. Okay, so enough pressure is building up in the ventricle, and then you can't see it on this cross section, but behind this area there is an aortic valve, and the aortic valve is going to have enough pressure to open it up, and then pshoo, blood's going to go around. Blood's going to take a couple of directions here. It's going to go through this aortic arch. You're going to have a couple offsets that go into the head, into the upper limbs, and into the neck. And then it's going to literally go around, curve down, and then boom, down. And it's going to have a bunch of branches that supply the rest of the body with oxygenated blood. Okay. Here's the outside of our heart. So the outside of the heart, you can see a little bit better of the vessels here. So we have this vena cava here, the superior aspect and inferior aspect. We have here the left pulmonary artery. Does the left pulmonary artery have oxygenated blood or deoxygenated blood, guys?
Deoxygenated.
Deoxygenated.
Okay, perfect. This right here is what the atrium of the heart would look like. They kind of look like little armor or little floppy wings on the outside here. And they look very different from the ventricles, which are more of a thicker muscle because they have to do more work. The atrium just received the blood from wherever it's coming from. The ventricles are responsible for pushing it out. Okay, and what we have here is we have some of the coronary arteries. So when someone has a heart attack, what's happening is that these coronary arteries get blocked up by something called cholesterol. And when you can't get blood to an area, what do you think is going to happen to that tissue?
Tear,
Asphyxiation?
stretch.
Asphyxiation is a good call on that. Yes. So the tissue's gonna die because there's no oxygen getting to it. So that's called a myocardial infarction or a heart attack. So what's happening is that whether genetics, diet, whatever we want, whatever is going on in the person, it's going to cause enough that we can't get blood through here, and it's going to cause heart tissue death. Right here is the left anterior descending artery. And that's known as unfortunately known as the widowmaker. It supplies the majority of the heart itself on the anterior aspect. And if you have a blockage here, it's normally going to be the heart attack that doesn't allow you to live through. Okay. And then we also have the left coronary artery that supplies the left atrium and above here. This is all coming off the aorta because it's oxygenated blood. Okay. So off this little aorta, if we had the posterior view, you would see that we'd have the left coronary artery, a right coronary artery, a left anterior descending artery, and then if we had a posterior view, which you will on your lab, you will see a posterior descending artery. Okay, those are the arteries that I want you guys to know about. I'm not super big on the veins because most of the time veins aren't, for some reason, quizzed on that much, or at least for dental hygiene boards are not considered as important. But because you will see you'll see patients in your clinics that have heart attacks, it's good to know what happened to them. Okay, and then with vessels in the heart, so there's a little bit of fat here that's meant to protect it. We don't want just those vessels just lying around and able to get crushed at a moment's notice. This fat here is meant to protect the heart. Okay. Oh, I do have a posterior view. Sorry, posterior view right here is showing that posterior descending artery right here, or posterior intraventricular artery, depending on which anatomy person you ask. And then the only vein that you guys are responsible to know is the cardiac sinus. So cardiac sinus is the major vein that's going to bring deoxygenated blood back from the heart muscles into the heart to do the same thing that it does with the rest of the body. Okay, so we kind of went into, I like to use the pictures more to describe than kind of off the slides, but for slide purposes, you have the atria, which are the receiving chambers. You got the superior vena cava, inferior vena, and coronary sinus. Those are receiving blood away from the body, bring it to the heart. Left atrium that receives oxygenated blood from the lungs. It has full pulmonary veins that return blood from the lungs, and also has specialized muscle that I did not mention. Sorry about that, guys. Has specialized muscle up here which you can kind of see. It's called pectinate muscles. And pectinate muscles are there to help allow some elasticity, to allow more filling to occur. So we need to accommodate for what we need. So that's why the outside of the heart looks like little wing flaps, because when there's nothing in here, it's pretty flat. But when it's filled up with blood, it balloons out and allows the pectinate muscles allow for that ballooning to occur. Okay, and then we're looking again here just for a little rehash, looking at what we're looking at. So we have the atrium up here, ventricle. We have the tricuspid valve right here, the mitral valve right here. We have the pulmonic valve over here. And what we can't see is if we cut away this little area, we have the aortic valve. Those are the valves that you guys are responsible for. Okay, and there's also, we already discussed a little bit this about the heart, but the what we see, if we were to open up a person's chest during an autopsy or during a cadaver dissection, you would actually see most of just the left ventricle. That's what, when you're looking down at the heart is positioned not dead line in the center like this. It is, so I'm going to use my phone here. So the heart is positioned at an angle. Sorry, I should do it the correct angle. At an angle. So this is the base up here, even though that doesn't make much sense, and the apex is down here, and it's going to look like an ice cream cone. So what we're seeing is that the heart is actually turned out this way. We're seeing most of that left ventricle. We can see a little bit of the right ventricle, but not much of the atrium. So when someone's doing an x-ray and they're saying, oh, is the heart enlarged or not, they're only seeing that little small snippet there. That's all you can see, okay? And then as far as, sorry, the right ventricle, sorry there. As far as the specialized muscles to know about for the ventricles themselves, we kind of discussed a little bit with the trabecular carne. Inside the ventricle right here, you're gonna see these little ridges. Those are trabecular carne. And then the papillary muscles are what helps those leaflets open up. Okay. And so this is if we took the heart and we basically took its cap off. So anyone remember what plane this is?
Transverse.
Yep, whoever said that, correct. So transverse cut. We can see all the different valves here, okay? So here's that myocardium. So we're looking down on the heart, okay? So we have the mitral valve right here. You can see there's only 2 leaflets. We see the tricuspid valve right here. There's 3 leaflets. And then we have 3 cusps of the pulmonary valve and aortic valve. And this is a real heart, guys. This is, well, it's been fixed, so it doesn't look how it was in real life. But what they did is they just basically took off the aortic arch, and now you can see the different valves of how they look like in real life. When we get older, these valves can sometimes get what we call incompetent, and not mean that they're stupid or anything, but they just kind of, they can get calcified or they can get thinned out. And over time, you might hear someone say that someone has a murmur. Unless they're born with it, the murmurs are normally due to aging. And the most common ones is to have this mitral valve. It gets tired, and what happens when it gets tired, if it doesn't open up fully, it means it's stenotic. If it doesn't close fully, it means that it is regurgitation. So if it doesn't close fully, guess what's going to happen? If we're trying to pump against pressure and this valve doesn't close, blood's going to seep back up into the atrium. And does that mean the body's going to get a ton of oxygen? Not so much. Does the heart have to work harder if things seep back up because it's sensing the volume is there and it has to build up more pressure? Yes. So there's a lot of murmurs out there. That's, I mean, no one has to say, I have a murmur right now. But if anyone has a murmur that they were born with, a lot of times these are benign and not a big deal, but it's the ones that we acquire when we're much older that become a big deal. And sometimes what they do is they go in and they do a heart valve replacement. They use porcine valves, which is from pigs. And all they do is they literally cut this out, sew in another leaflet. Sorry if anyone's vegetarian. They cut this out, they sew back in another leaflet, and then it's there for a good few years. They also have a mechanical valve, which is a little more dangerous, and they can be used in any of these. And it's called a ball valve, where literally they take a little metal ball, put it in a ring, sew it into this little area right here, and that ball acts as the pressure monitor. And when enough pressure goes up, the ball comes up. When the pressure goes down, the ball goes down. So it blocks the little circle area from having blood go through to the rest of the heart if it needs to. Amazing what we can do here. Okay, so these little slides here just to say exactly. So we have the two atrioventricular valves, which if we can't remember, if we can't remember semilunar versus atrioventricular valves about where they divide things, the names normally say it. This is the fun part about the heart. If you forget something, if you can remember one part, you're going to remember the rest. So atrioventricular is the atrium and ventricular. It separates the atrium from the ventricular. So if you guys see, and I'm asking which one of these atrioventricular valves is on the left side of the heart, you would hopefully not pick a semilunar valve because that doesn't make sense. Okay, and as I said, it's all about pressure. You could do your din 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 right now because that's what most people do. Sorry, that was a David Bowie reference. So it's all about pressure. We need this pressure to be able to open up valves and get things moved around. So an example here is that we're looking right here at one of the valves right here, this atrioventricular valve. We're looking at it regardless of whichever side, it doesn't matter, it's the same jazz. Same thing is happening on both sides. So we have blood that's gonna fill the atria, it's gonna press against the atrioventricular valve, it's gonna increase that pressure, and enough pressure is gonna go and open up and it's gonna come out, okay? And once that blood starts, that volume, that pressure starts dipping into this ventricle, what's going to happen is there's not enough pressure to keep it open, so it's going to close. When we listen to someone's heart, we're hearing lub dub, lub dub, lub dub. That's what you're hearing. You're hearing these valves open and close with the stethoscope. So my job as a physician is that when I'm listening to someone's heart, I'm listening, one, that they're opening and closing at the right manner. Two, am I hearing any rumblies, which means there's a murmur? Am I not hearing any sounds, which means that maybe something's blocked? Those are things that a doctor would be looking for. As far as dental hygienists, it's really important to know about these valves because when you guys are doing work in the mouth, there are certain bacteria that you guys will learn about that can travel into the bloodstream and it loves to hang out on these little leaflets. And if the bacteria hang out on these little leaflets, it can build up called a vegetation and cause heart issues. So it's really important as dental hygienists even to know that what the impacts of cleaning the teeth actually can do on and taking care of someone's oral health can do on the heart as well. We're all interconnected. So just because you guys work on the mouth only doesn't mean that the rest of the body is infected. Just because I work with kids doesn't mean that the rest of the world is not, I don't see other people. So we're coming here at the atrioventricular. Again, we got to remember it's all about that force, okay? So when it's closed, that means the ventricles have contracted. So if the ventricles contract, that has pushed the blood out of the ventricle into the rest of where it has to go. If there's no blood in here, there's no pressure building up, so that's why these valves close. I feel like I've butchered the pressure thing to the oblivion. Does anyone have any questions about pressure or what it's doing as far as heart and volume? Negatory. All right. Sorry. Of course, they decide that they have to mow the lawn the second I start lecturing. Okay. Can you guys hear that pretty loud or? Nope. Okay.
No.
Perfect. Okay. So same thing, semilunar. See how different they look here? So the leaflets look like they were little triangles. Semilunars look like little moons. And what they do is they kind of hang out. There's one on each, there's three of them, and they all hang out around the vessel. And when they open, there's a little flap that almost looks like an open cup. And then when the pressure hits, it closes. So even though they look different, they have the same function. So with the semilunar valves, when the ventricles contract, you have a lot of blood in there. The blood is going to force the blood, sorry, we'll try that again. You're going to have a lot of blood coming in. That blood is going to push against that myocardium. That pushing is pressure. And when that pressure is high enough, it's going to eject the blood out. And that's normally at 120 millimeters of mercury for systolic. It's going to push out the blood to the rest of the body. So it's like holding a hose, waiting for enough for it to overcome you holding the hose and closing it. And your hand just can't close that hose anymore. And it goes shh, and everything comes out. Okay, same thing. So the same idea, but different story. So remember, if there's not enough pressure, that means the ventricles are relaxed. That means that the valves are closed. When the ventricles contract, that is systole. So when you, I don't know if you guys have learned your vitals yet. Most people have at this point in the lecture, but I don't know if they can physically teach you how to do that right now.
We're
But
only
when
just now starting into that lecture.
Okay,
in
well, all right.
Andrea's
And I
class.
didn't line this up as perfect as I did last quarter. Sorry. So when we're taking a blood pressure, we're looking for two numbers. We're looking for a systolic, which is when your heart is contracting. And when the heart's contracting, that's going to cause the highest pressure. And that's really measuring how much the ventricles are contracting, how much pressure is there. And then when the ventricles relax, that's diastolic. So the magic numbers that people are looking for is to not go above 120 for systolic blood pressure and not below a 80, sorry, not above an 80 for diastolic. When those pressures gets too high, what happens is that it creates so much extra work on your heart that the heart is a muscle. And what happens when we work our muscles? Do they get smaller or bigger?
Bigger.
Bigger.
Now, it would be convenient to have a bigger heart muscle because you would think it works stronger, but it doesn't have a ton of space for it to be in. So if we make bigger heart muscle, then we actually make the heart work a lot harder because it has to make sure, one, that it's not hitting the pericardial sac. Two, just because it's bigger doesn't mean that it's going to work better. It's going to require more pressure more pressure and more blood to trigger that heart muscle to want to work and to contract. And it's actually creating a lot worse issues. And there is such a thing as low blood pressure, but it's not very common.
Dr.
Okay.
Wood, can I
Yeah.
ask a question about that?
Yep.
If you work on your blood pressure and you exercise and are eating better, can it like get smaller and healthier after it?
Once the heart is bigger, you can't really, the only way to make something, well, yes and no. So it can't really reverse making it super big, but you could definitely prevent it from getting it bigger in return. So definitely exercise, diet, all take a play into heart health. The more thing that we're worried about is rather than if the damage is already done in the heart wall has been made bigger, we want to make sure that blood pressure stays low so it doesn't get any bigger there. Okay, so as I said, there was two different types of murmurs that you guys should know about because you'll see it come up on charts. And yes, this is not a pathology class, but it is important to know about these. It helps understand how valves work. So we have called incompetent valves. Remember, they're not stupid. They just don't want to work as well. And they have backflow, so that creates a problem. And then we have valvular stenosis, which means that either calcium or vegetations or something is preventing these valves from fully opening, which means that the heart has to now use more force to try to force this valve open and more blood to come out than it wants to, okay? And we already talked about the different types of valves that you can have. Okay, so remember, there's two different circuits that we have to remember about, the pulmonary circuit and the systemic circuit. Okay, so the pulmonary circuit, is there gonna be deoxygenated blood or oxygenated blood in there?
Deoxygenated.
Perfect. And then the systemic is going to have oxygenated. So I'm going to say this over and over again. You're like, Dr. Wood, we get it. We get it. We understand the flow of blood. But there's been countless times that this has been questions and it's been had wrong answers. So I want to make sure everyone understands this, not because I don't trust you guys, but because this is the practice boards that I've done, at least myself, this always has showed up on a practice board. So I figure it's a good thing to know. Okay, so we have blood coming from the outside of the body. It's been used up by the muscles, by our tissues, by our organs. It has no oxygen in there. It's going into the superior vena cava. Does anyone remember which atrium it's dropping off to? Right atrium? Sounds good?
Right.
Okay. Right atrium is going into the right atrium. There's a little bit of pressure, there's less pressure on this side than the left side, but it's enough pressure that's going to cause this tricuspid valve to open. Blood's going to flow into the right ventricle. Right ventricle, blood volume is going to build up. It's going to cause pressure. That pressure is going to open the pulmonic valve. Pulmonic valve is going to send things from the pulmonic trunk, which is also known as pulmonary artery. It's going to bring blood away from the heart to the lungs to get oxygenated. The lungs are going to do their magic. It's going to oxygenate in the blood, and then blood is going to come back into the heart via the pulmonary vein, which is on the next one. Sorry. So it's gone through the body. It's done exchange. We got some blood here that's oxygenated. It's coming into the pulmonary veins, into the left atrium. Blood is going to pull up, and volume is going to cause pressure. Pressure is going to cause this bicuspid or mitral valve to open. Blood is then going to go down into the left ventricle. Blood volume is going to fill. It's going to push against the wall, causing pressure. Pressure is going to build up, and open the aortic valve and have enough pressure to eject the blood at a pretty strong velocity to the rest of the body. So one of the questions I asked, and some of you guys had really creative answers to this, and thank you. I love the good laughs. I do understand you guys are taking this class seriously, but I do love the good laughs. It is welcoming. So when you see someone getting their blood drawn, why do we go for their veins and not the arteries? We go for the veins because there's lower pressure. And also veins are closer to the surface than arteries. Body has innate knowledge that it knows it needs to protect what it needs to protect. Veins are lower pressure. So if someone cuts a vein, or say you're hiking out in the middle of nowhere and you cut a vein, you don't need that much to make it stop. You just need a little bit of pressure. But if someone severs an artery, like say you're hiking up Mount Rainier and somehow you land on a tree branch just right to get into your femoral artery, blood, it's like the movies. It comes out, it's gushing, it's geysers. It kind of comes out pretty fast because it's such a high pressure. So we definitely don't want to pierce an artery with a needle for blood if we don't have to, because that would be setting up the human's race for bad things to come. Okay. Okay. So we went over the pressure, the pathway about 50 bajillion times now. If there's any questions, please ask me. But as far as the pathway of the blood, you need to know that. That is going to be on every single quiz that has to do with the heart, every single test. There's going to be a question in 2 years when you guys take your boards, okay? If there isn't, you can come back and say, Dr. Wood, you were wrong, but I make you bet about 2 pennies, because that's all I want to bet right now. 2 pennies that it will be all your test. You're like, great, Dr. Wood, that doesn't sound very promising there. Okay. We will take our first break in about 6 minutes, guys, okay? Okay, so left ventricle is hot and much thicker. It's about 3 times thicker than the right side of the body. And why is that? Because it needs more pressure, okay? Pulmonary circuit, low pressure, systemic, and it's also keep in mind that the pulmonary circuit doesn't have a ton of length to go. It literally just has to go the heart to the lungs, which are right next to it. The systemic circuit is longer. It's got to go to different areas of the body. So we need more pressure. The pressure is going to cause speed and ejection fracture to be able to get out into the rest of the body. Okay, so this is what another cross view, a transverse section. So just to bring it on a little bit more importantly is that we see that this right ventricle is very thin, left ventricle very thick, okay? Right here is the intraventricular septum. Sometimes people are born with holes in their heart. I don't know if anyone's ever heard the term of hole in the heart. So we have that foramen ovale, which we discussed at the beginning of the slide, which is between atrium to atrium. That was to bypass the lungs, because in utero, until that baby comes into the world and has its umbilical cord snipped, not snapped, hopefully they're not like going like that, snipped, they are still getting their oxygen from the placenta. They are still getting it from whatever blood flow is going through the amniotic fluid, getting exchanged. We'll go into that in week 12, all about in utero. But until that happens, it needs a way for it to get around. The second the baby comes out, within seconds, and I mean with seconds, after that umbilical cord is cut, these all of a sudden grow super fast and this foramen ovale gets closed. Sometimes when the heart is developing, there is an extra hole here, and that is very dangerous. Because what's happening is it's higher pressure areas. So once they are born, their umbilical cord is cut. When they're higher pressure areas, if we're trying to get blood to get oxygenated, and then we need to get oxygenated blood out to the rest of the body, what do you think? Is that going to serve us as adults to have mixed blood with deoxygenated and oxygenated? No, it actually creates a lot of dangers. And sometimes kids are born with these vessels up here, or in the wrong order, or they're attached to the wrong ventricles, and that could create lots of issues. Jimmy Kimmel, not to bring him into the picture, but he's like, wait, I'm not getting paid to get mentioned in this lecture. Let me get that. Jimmy Kimmel's child, I don't know if anyone's familiar, but his son Billy was born with a heart defect known as tetralogy of Fallot. So what ends up happening is that we have a lot of things that are open. We have vessels that are in the wrong way. And then one of these valves is actually made incorrectly too. So it requires multiple surgeries throughout a kid's life. And depending on the extent of it, it could be easily fixed, but normally they're still getting surgeries till about age 18. And then they have to be monitored very closely. Okay, on that note, I'm gonna let us take our break a little bit earlier just because I need some water. If you guys can come back at, hold on, 9:20, at 9:30, it'd be greatly appreciated, okay? Thank you guys. And okay, so there are a couple of questions. Is there any way to reduce the size of blockage after it builds up? So yes, depends on the size. Oh, sorry. One of these. Okay, I can't insert stuff. All right. Sorry, Apple products have no idea how to disconnect all them altogether. So there is a little bit of a way. It depends. It depends on the size and depends on the person. A lot of times what we can do is we can give antioxidants or medications that reduce, well, antioxidants help the health of the vessel itself from a naturopathic standpoint. Sometimes someone will be put on a statin medicine, which helps reduce your cholesterol altogether. The real telltale is how do you prevent it in the future? And are there signs of a blockage before someone has a heart attack? Normally they have something called angina pectoralis, which is where they have chest pains. It's not a heart attack, but they feel like they're having chest pains or that kind of come and go. At first it happens with just exercise, and then it starts happening at rest. And then the real telltale signs of a heart attack are at least in men. In women, it's not predictable. All different. Most women, and this is not to scare anyone, most women, if they're going to have it, they already have some underlying conditions that are making them more at risk. But typically they'll feel back pain, nausea, vomiting, dizziness, not your typical things that you think of with a heart attack. For men, and it has a lot to do with estrogen, with men, you have those, I feel a crushing pain in my chest. I have left arm pain going down my arm. I'm sweating. I can't breathe. It feels like something's crushing. You'll have some jaw pain. Those are signs of blockage that has now led to a heart attack. At least what I do as a naturopathic standpoint is I make sure that if there are any things that we can do to prevent things, we help that out. There are therapies that known as, I don't do them because I don't feel safe with them, but they're called chelation. And the idea is that you can chelate some of the calcium and take it off, but I don't see enough evidence-based medicine to support that. And I only practice evidence-based. So that's that after all that jazz. Okay, let me get this to come back up. I'm going to share our screen, or I'm going to attempt to share a screen again. Okay. There's someone listening to new age music in the background. If you can mute your thing, it's totally cool. I love new age music. It's cool, it's hippie, it's vibe. But
Sorry, I just realized that's my husband's doing meditation.
great, good for him.
Yeah.
Awesome for him. I missed mine this morning, so good for him. He'll live vicariously for us all. Okay, so we're up to what it looks like. And speaking of, I didn't even realize we were at that part. Where someone asked the question about what it's going to feel like. So angina is exactly what I was just describing to you. The cells get weak. You're feeling a little bit of pain every now and then. It's not a heartburn. It's more like it feels like someone's I've never had one, so I can't tell you from personal experience. But from what my patients have said, it feels like someone's holding your heart, kind of like Indiana Jones style, if anyone recalls that movie, and just holds it and pushes it with their hand. And you could feel that. Hopefully they're not taking out the body going, ah, but if they are, we have bigger problems than just angina. And then the heart attack is basically what happens is that those coronary arteries are blocked. You get no oxygen. Sometimes if it's a short enough period of time, the crappy, yucky tissue that's been kind of eaten away at will get cleared. But what normally happens is that the cells die and scar tissue gets placed down in the myocardium. And that scar tissue cannot contract. It cannot beat. It cannot work as one. A big enough area of that area gets scarred and the heart's not going to work anymore. On a happier note, let's talk about some microscopic anatomy. Segue, not had. Okay, so happier note, not really, but cardiac muscle. So we learned in the beginning of the course that cardiac muscle is a little bit different than all the other different muscles. So it has striations, yes. Is it, do we control our heartbeat, or does no control of heartbeat? No, I see
control.
going this way, so I'll take that as a no. So no controlling of heartbeat. So that means autonomic, okay? So that's a big thing. Skeletal muscle, it's striated, but we have control over it. Cardiac muscle has these special things called intercalated discs. And what they do is they provide little junctions between each heart cell. So intercalated disc, here's one heart cell. Intercalated disc, here's the start of another one. What it does, it allows for electricity, that are electric beats of our heart, to go through and work as one. So it's called a functional syncytium, which is a fancy term for lots of different cells working together to beat as one. You know, I'll do this now and do kumbaya if you want. Okay, so the big thing here, if I showed a slide of this, you would know that it has one nucleus, not multinucleated. You would know that it was striated, and you know that intercalated discs is what makes the heart so different. And if we looked at skeletal muscle, you would see that the skeletal muscle looks like all one big sheet. Here we're seeing is it's branched, and it's branched because that myocardium is that skeletal arrangement needs to be branched in order to do the swoosh and the push, okay?
But does each disc have its own nuclei?
No. The disc itself is just like a little gateway that allows things to flow through it. It's a little junction, little gap.
Okay.
And they're all anchored together with desmosomes that go around it. So skeletal muscle versus cardiac muscle. Even though they're both muscle, they have different ways that they work. So the similarities is that muscle contractions need a depolarization action. So the nerve has to fire. They both have T-tubules where the depolarization causes sarcoplasmic reticulum to release calcium. And then we need the calcium to bind to troponin to allow the troponin myosin actin bridges to hook, pivot, and move. Okay. How they differ is that they have different types of cells. They have the intercalated disc. We chat about that a little bit. We have two different kinds of muscle cells, and the big difference between muscle cells is self-excitable. So skeletal muscle needs an action potential to be fired from somewhere else. But once an action potential is fired in a cardiac muscle, the cell can make its own little action potential and get excited. So we have two kinds of cells in the heart that we need to know about. We have contractile cells. Hint, hint, nudge, nudge. That is contraction. It has the name in the word. Don't we love it when anatomy does this? Then we have pacemaker cells, which set the pace of our heart rate. So when you're hearing someone say that they feel like their heart's fluttering, that's a heart rate issue. When you see someone get something called an EKG, and funny thing about EKGs is that there's a normal pattern. Anyone who has a tattoo of an EKG pattern actually has an arrhythmia because they think it looks cool, but it's actually a deadly arrhythmia that people get tattooed on themselves for their EKG readings. So yeah, let's check before we get tattooed for permanence that it's correct. Okay, so pacemaker cells, they set the pace, the heart rate. They initiate the depolarization of the entire heart. Okay, so these cells are very important. If these cells get messed up, then we have a big issue. Okay, heart contracts as a unit. So in the muscles, in the skeletal muscles, they contract kind of different points. The heart is one, it's one big unit. It says a functional syncytium. I keep saying that word because it's a word that's going to be important. If they all work as one thing, then it's a really effective pump. If one area is pumping here and one area is pumping here, you're not going to get enough pressure to get that blood moving. And the big difference here is, yes, we need calcium in the skeletal muscle to allow for the troponin myosin sites to be active. But what's different in the skeletal muscle is that we get an influx of calcium that triggers even more calcium to be released. So it's calcium, calcium, calcium. That's what, if there was a question on this, you would hopefully pick, that means once an influx of calcium from the extracellular fluid comes out, then there's calcium that's stored in the sarcoplasmic reticulum that then gets triggered. So it takes the same exact calcium to trigger calcium to make made more of, okay? And what happens in depolarization, it's not so much about it's not, there's things called slow channels, and the slow channels for calcium, they open up, allowing the calcium to enter the cell. And once that calcium enters the cell, then sarcoplasmic reticulum is like, I can sense there's more calcium here. Let's get some more out because we need it for cardiac muscle. Skeletal muscles don't use extracellular calcium. They only use what's already inside their cells. Okay. And then one thing that we kind of briefly discussed about muscles was tetany. So tetany means that a muscle contraction gets sustained. That's from from tetanus. That's why we get a shot to prevent tetanus. What tetanus does, it makes it so the cross bridges can't disrupt, and you just stay like this the entire time. You can get an antidote, don't worry, but it's painful, and why risk it? But in cardiac muscle, you can't have that. You can't, because that wouldn't be really effective of human bodies to, if you had tetany, then you would, if your heart couldn't contract, you would just not be there. So for whatever reasons that be, science has made it that you cannot have tetany contractions in cardiac muscles, okay? And this allows the heart to relax. That way you can keep beating. If you have tetany in the rest of your body, your heart can still beat and get muscles what they need, okay? Other things is that our muscles, has anyone heard the difference between training for working out, training anaerobically versus aerobically? I see a few heads nodding, okay. So anaerobic allows our body to be more efficient for fast speed, high sprint type of style. And aerobic is that slow to the go. So we're walking, we're swimming, those are aerobic things. We do that because it's good for our heart, right? We hear about why it's good for heart. Why? Because aerobic, our heart only needs air, oxygen to do respiration. It can't use anaerobic to do any of its work. So the heart relies almost exclusively on aerobic respiration, which means it needs oxygen to work, okay? They have more mitochondria. So cardiac muscles have more mitochondria, and mitochondria are responsible for making energy and ATP. We'll learn next week they play a huge role in respiration, okay? And both sources, so what happens if we don't have a ton of oxygen? What we can do is that we can use some other fuels to adapt, but we really need that oxygen available. A lot of times if someone works out really hard, they'll feel like a burn, like you feel the burn, that's amazing. That's lactic acid that builds up in your muscles, and that once you're past that aerobic zone, the lactic acid is used anaerobically. We can sort of use that, but the heart kind of looks at it and goes, I don't like that crap. Let me try to have something better. And they want the oxygen. And I just spit out into my room. I just realized that was gross. Sorry, guys. Okay, so we have the rhythm. We have the basic rhythm of our heart. So inside the heart, there's an electric circuit. It doesn't have a plug or anything. You can't really charge us against a wall. If we were, then we'd look at the Terminator. But it has its own built-in, not true built-in nervous system, but its own ability to work as a nervous system itself. So we do that with the intercalated discs, and then we do that with our pacemaker cells, okay? So we have a different way that the muscles work as far as pacemaker cells. So if you remember the action potential in the muscle, it would do this big rise, get a peak, and then it would fall down, and then you get this refractory period where other things can occur. What we have in the cardiac muscles, that we get this big peak, but we need that to be sustained for a little bit so we can all beat as one. So it has this it almost looks like a little plateau, and then it comes back down. Okay, and I have it on here on the slides for you guys to read at your leisure about the differences between the sodium and potassium channels. So pacemaker cells here, now remember we still have a resting membrane potential, so that's still got to be excited and bring up. We have the pacemaker potential, which is the slow sodium channel. So it's still the sodium that's going to cause the depolarization. Then the depolarization occurs, but then calcium channels are playing a big role here instead of just sodium and potassium. Calcium is the big player here for allowing the more of the action potential to occur. Okay, and then we have repolarization, where we know that the potassium channel is open, more potassium comes in, and then you're back at that negative 70 charge that we want to be at. Okay, so here is what a pacemaker cell would look like. So pacemaker cells, so what I was discussing about that plateau was the actual contractile cells. These are pacemaker cells, okay? So pacemaker cells, they all just one beat, and they work together. I'm not gonna hold you guys responsible for knowing the steps of this. This is just here for your I guess you're like, Dr. Wood, this is not really a pleasure to read these little things. But if for those who want to know more inner workings about how it works, I really just want you guys to know that the pacemaker cells have a different type of action potential than the contractile cells. Okay. And then so we don't have a plug that we really plug into, but we need things that work in an order that works for the rest of the heart. So we have what's known the electrical system, which is nodes and a way for the electricity to go in the same fashion throughout the heart to allow for all these depolarizations to occur so the muscle contract. So what happens is that we have these specialized areas. So this is you are responsible for knowing. So in order for the action, for the heartbeat to beat in a conduction, so it beats at the same manner, it needs to go in this order all the time. So the first one is our pacemaker area. It's the SA node. When someone says that they got a pacemaker placed in their heart, it's because the sinoatrial node is damaged, whether it's from a heart attack, There's allergies, not COVID, guys. Whether it's a pacemaker cell, if the pacemaker is put in, it's because its SA node was hurt somehow. SA node is the most important node. It's going to set the beat for the heart. So the SA node has an electrical signal that jumps to what's known as the AV node. So AV node then gets this little symbol, signal, and is like, okay, what do I do with it now? So what does it do? It goes from the SA node to the AV node. It goes down this thing called the atrioventricular bundle, which is like a little bunch of wires, not real wires, but theoretical wires that are going down to the heart. It's then going to go to the bundle branches. The bundle branches are supplying mainly the area of the ventricles. And then what it's going to do is going to what's called the subendocardial conducting network. So we go from the bundle branch. You might also hear it as bundle of His is a common term that people hear. We got bundle branches that come out, and then it brings it out to the rest of the heart. So if this is damaged, bad news bears. If this is damaged, bad news bears. Okay. But the other thing that is, if this is damaged, the SA node is damaged, then the AV node will try to take over. It's just not as strong and not as good as a signal conductor for the rest. So that's why when people get a pacemaker, it's mainly because this SA node stops. So the order that you guys are responsible for knowing is that it goes from the SA node to the AV node to the AV bundle, also known as the bundle of His, bundle branches, and the subendocardial. Basically, it's a whole entire of branches of networks out here that look like jazz hands. Okay. So sometimes we'll hear people say that my heartbeat is feeling funky, or I feel like there's a butterfly. Like when you get nerves, that's not an arrhythmia, that's just your autonomic nervous system. But some people, when they're not nervous, feel this strange like butterfly sensation in the heart. That's called an arrhythmia. It means that something along that electrical impulse is not getting sent out the correct way. Sometimes what happens is that it's not even damaged, it's just that for some reason the electrical impulse is just not working correctly, and we can't figure out why. There's a condition known fibrillation, which means that these electrical impulses are happening really fast, which is causing the heart to contract irregularly. AFib, or atrial fibrillation, is very common in the elderly population, mainly just because people are getting old and the heart's getting weaker. Okay. And sometimes you'll see the like Grey's Anatomy clear, and they do the little pads there. That's because what they're doing is they're using electricity to help this fibrillation calm down. They're giving the body a jolt of electricity, so our electric units can be like, oh, wake up, hold on, what was here? It interrupts the signal, and the body's like, wait, what's going on here? And then it's like, oh, let's do what we were normally doing. And they try to contract back, or they try to send the electrical impulse in the correct manner so they can have a better contraction. Okay, so we have two centers of the brain that are responsible for our heart rate. It's the autonomic nervous system. We cannot control our heart rate, but it's in the medulla oblongata. So actually when, Waterboy with medulla oblongata, they were a little bit off about what it did in that movie, but I ruined everything for you guys, sorry. But with that being said, there's a cardio accelerating area, which guess what? That's sympathetic because it's making your heartbeat faster. And then there's an inhibitory area in the medulla oblongata, which makes the heartbeat slower. The heart rate, what you really need to remember about for nervous system is vagus. Okay, the vagus nerve is responsible for the autonomic nervous system for the heart. So at least in my field of naturopathic medicine, I see a lot of people work on what's called vagus nerve stimulation, which there is evidence base that shows that it's pretty good to use. And then what they're doing is they're trying to stimulate the vagus nerve to calm down or speed up depending on what they're working on. But the take-home message is that autonomic nervous system is what's controlling our heart rate. Sympathetic means our heart rate's beating faster. Parasympathetic means we're calming down, so our heart rate is slower. Okay, and this is just a little looking at the pathway here. So here's the medulla oblongata. It's coming down here, and then you got the vagus nerve. Vagus nerve then kind of joins one of its little ganglions that were hanging out in the autonomic nervous system along the spinal cord, and it sends out all these little pathways to the heart. Okay, so we talked a little bit about the action potential of the pacemaker cells. So remember, it goes up in a rhythm. It's not, it doesn't have, sorry, it goes up, down, up, down. The contractile muscle cells, and sorry to confuse you guys, I confused myself on that one when I was just lecturing, is that the contractile muscle cells are what have that plateau. So the plateau is, it goes up, 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 and then you'll see it kind of do a little wing and out, and you'll see what I'm talking about in a moment. So with the action potential for contractile cells is basically the same type of style, except for we need sodium to open up, to depolarize. Depolarization then causes the slow calcium channels to open up. And then we have a contraction. We know the steps of what the contraction are. Still uses actin and myosin. I'm not going to go into that much depth for you guys. So contraction of the cardiac muscle is longer than skeletal muscle time-wise. Why? Why do we need that? This is really important. We need the sustained contraction to ensure that we're ejecting the blood out as much as we want to. And then the longer refractory period makes it so we can't get tetany. So those are two take homes that I want you guys to know. If something is in all caps, and it's not that I'm yelling at you guys, if something is in all caps on my slides, it normally means that you need to know. Or if it's bolded, I want you to know it. I'm not yelling at you. And this guy is what's getting, he's not becoming a robot. He's getting what's called a 12-lead ECG. So when someone goes into their cardiologist because they've been having some heart things that they want checked out, they're going to put these little sensors that sense the electricity that's going through the heart. It's going to show an image on a computer screen, and that's that little one. We'll see it in a second. That's this little image right here. So a lot of times what we'll see on those tattoos that I made, you'll see it goes like this, and then also it goes really fast, and then it goes flat, and then it goes fast. That's an arrhythmia. This is if you want a tattoo of your heartbeat, this is the one to do. Okay, this is a normal heartbeat. Don't go get tattoos of this, guys, but unless you want to. So what's happening here is that when we're looking at EKG or ECG, same thing. We're looking at, on a graph, what we're seeing as far as electrical impulse. So we have a little wave here called the P wave, and that's where the atria have depolarized. If the atria have depolarized, they probably have contracted as well. Okay, then we have this QRS complex, and this is where the ventricles depolarize. And then we have a ventricular repolarization. So we can't, the atria are repolarizing, but it's being hidden because this ventricular repolarization is so powerful that it's hiding the atria. So we have P wave, we have the QRS. So P wave, if you were to see that on a test, you would remember atrium, which is all about the atrium. We would see QRS complex, it's all about the ventricle. And then the T wave is ventricular repolarization. When someone has a heart attack, sometimes this T wave is inverted. So it's not like this, it's going the other direction. Sometimes this QRS complex is really wide and what looks like an unaffectionately called the tombstone appearance of a heart attack, which means this QRS complex actually comes out like here and looks like a tombstone. So we can do a lot of information with these EKGs just by taking a look at the patterns that we see on here. And we spoke a little bit earlier about the differences between systole and diastole. So systole is when your heart contracts. Diastole is when your heart relaxes. When we're doing the blood pressure, we're looking for the systolic pressure, which is the pressure that your heart was at when it contracted. Diastolic pressure is when your heart was relaxed. We more pay attention to the pressure of the systolic, the upper number, because that's normally the one that changes first. And it's the one that's more dangerous for, if that's a higher number, then that leads to more issues. So if that diastolic number is above 80, then we start thinking there's something, the heart is not relaxing fully or not relaxing properly. And then we have a cardiac cycle, which is a full, complete one heartbeat. So the atria go through relax and contract first. Sorry, contract and relax first. Then the ventricles follow, and then through the pressure, and that's what we're seeing on the EKG. It's called the cardiac cycle. Okay, and then we talked a lot about pressure. So mechanical events of what's going on when we are trying to get pressure and contract. So the first event is that the ventricles have to fill. So this is happening what's known as mid to late diastole. So the atria have now contracted. They're relaxing after this. They're about to go in diastole. When the ventricles are relaxed, if you think about it, if the ventricles are contracting, they can't fill with blood. They're busy trying to push things out. So ventricle filling is happening in late diastole when the heart is relaxed. The pressure is low at this point, and most of the blood is just flowing through because of gravity, basically. Gravity's just going, okay, we're just going to come. There's nowhere else to go except for down, so we're just coming down. Then you're going to have depolarization occur in the atria. And what we're looking at there is that the big key terms that are bolded here is that ventricular filling. What we're looking is what's at the amount of blood that's in that heart at the end of this relaxation is what's important. So ventricular filling, mid to late diastole, and then what we're left with at the end is what's going to be important for the rest of the body. The heart has a special kind of contraction called isovolumetric, which means that it needs the volume to build up to make pressure. And when that volume builds up to make pressure, it causes contraction. And then we have to have relaxation. We can't just be contracted all the time. We have to have relaxation. So the isovolumetric contraction, that is our systole that we're looking at. Isovolumetric relaxation is diastole. And we'll see that as the T wave. And then we have a very important term known end systolic volume, which means you can't have the blood completely empty at all times. There's going to be a little bit left over. So we have a little bit at the end of systole, what didn't make it out, which is end systolic volume. So this is really small in my screen, but this kind of links everything together. What you're seeing as far as the cardiac cycle, where your QRS meets. This is a good study tool for you guys at home. As I said, hearts, the lub-dub. So that is heart sounds when we're listening with the stethoscope. The first sound, the lub that you're hearing, is your atrioventricular valves. They're closing, and that's the beginning of ventricular systole. And the dub, the second sound, is the aortic and pulmonic valves starting to close, and that's the end of diastole. Okay? And then the pause that we're hearing, so it's lub, dub, lub, dub, lub, dub. The pauses is that the heart's relaxed, so we don't really hear you can't really hear something open, but if you hear it go like that, you can hear the snapping of it shut, and that's the sound you're hearing from the heart. So if you guys have a stethoscope at home, I don't know why you would have, but if you happen to have one, you're more than welcome to take a listen. There's different, we kind of went through this a little bit earlier in this lecture, but if you guys, I don't know if you have to learn how to listen to the heart sounds. I don't think so for your purpose of job. You just have to know how to do blood pressure. But in case you were ever told to listen to a heart, you'd be listening for these 4 basic areas. So the aortic valve could be heard best at the second intercostal space because that heart is tilted. The pulmonic valve being heard best at the second left intercostal space. Mitral valve has been heard at the 5th intercostal space, which is the apex. And the pulmonic valve can be best heard at the 5th intercostal space on the right. So that's why when a doctor's going 1, 2, 3, 4, they're listening for the different heart valves. They're not just doing it to do it. Okay, we already spoke about heart murmurs, so I really don't want to go into any more depth about that. What I do want to talk about is how do we regulate this pump? There is some equations here. It's math. I'm not going to have you guys do math. Don't worry, but I do want you to be familiar with this equation because it plays a big role in how the rest of our body determines how much we need to pump, how much volume we need to make. So cardiac output is how much blood is being pumped out by a ventricle in 1 minute. And how do we determine cardiac output? We take the amount, the heart rate, so how many times the heart beats per minute, plus that stroke volume, so how much blood is getting forced out of the ventricle each beat. And then we add this all together, or we don't add it, sorry. We take the heart rate and we times it by the stroke volume, and we figure out what the cardiac output is. When cardiologists are trying to figure out if people need medications, if they need heart replacements, if they need little angioplasties to help out, they look at this equation and they go, how's the cardiac output doing? If it's low, then that either categorizes for different heart conditions, or we need to do a surgery. So this is why this is important, but also it's important for us to understand, because the main idea here is that I want you to understand is that the heart rate, so how many beats per minute we're having as a heart rate, and the stroke volume is what's dependent on how much blood is getting put out to the rest of the body. Because here's this person running on this lovely road. So this is a great study tool. I love this because it kind of has everything out in one fell swoop. So when we increase cardiac output, it's because one of these have been increased, because it's a multiplication. So if we increase one factor, then the other factor is going to go up. So if we increase stroke volume, then we're going to increase the cardiac output. If we increase heart rate, we're going to increase the cardiac output. When we're running, we want to increase our cardiac output for a good reason. If we're running, we need our legs to have blood, we need our lungs to have blood, we need everything to get oxygenated so we keep running. So when this person is running, they're going to need to increase their cardiac output by increasing that stroke volume, increasing heart rate. So there's a resting heart rate when you're just sitting here at this, hopefully no one's anxious, but normal heart rate is 60 to 90 beats per minute. When you exercise, there's zones that sometimes people try to get for. Anything above 110 is the fat burning zone. And then there's the intensity zone, where depending on your age and your height, it could play a lot of factors of how fast your heart beats. As we get older, we expect that our heart rate during increasing cardiac output is going to decrease. So we don't actually want it to get too high because it's accommodating for age. And then here you can see that in order to increase the heart rate, sympathetic or parasympathetic has to work. Same thing with stroke volume. We need to adjust how much blood is actually getting into the heart, and there's different ways to do that. Exercise, we're increasing the respiratory pumps, which causes more blood to come to the, so when we're working out, your calf muscles are actually going like this, and they're pushing the blood with the veins back up to the heart. And when they're doing that, so we can get more blood oxygenated. Okay, so the big key terms here for you to know are cardiac output equals heart rate times stroke volume. Heart rate is how many beats per minute your heart beats. And stroke volume is how much volume comes in with one heartbeat itself. Okay, and then how do we determine what's important for stroke volume? So how much of that blood volume is really going to be there per stroke of getting it out? We have to look at three things called preload, contractility, and afterload. Okay, so preload means how much the heart's going to stretch to accommodate for allowing blood in. So the heart has a lot of elastic fiber, so it's able to stretch. So when the blood is first coming into to the ventricle, it's got to stretch a little bit. It's got to accommodate for it. That's why it's able to expand and contract. So preload causes it to stretch. And then don't worry about the equation, but understand there's something called a Frank-Starling law of the heart, which means basically that if we increase the preload, the ability for the heart to stretch, we can increase the volume that's in the heart, that's in that area. I'm not going to make you guys memorize physics because I don't believe anyone's going to be a physicist. If you are, let me know. Okay. And then also when we increase the stretch, we're increasing the amount of tension that's there. So that's something important to know as well. So preload, if you wanted to know Frank-Starling's law, preload is basically just, and it's just volume. Understand it's volume that affects how much gets out into the body. I'm not going to make you guys memorize that. And then contractility means how much strength is in a given muscle length. So if we need to be able to stretch, but we also need that the heart has the ability to be contractile. And how do we do these? How do we influence the contractility? We can get sympathetic nervous system with epinephrine. That would, when the sympathetic nervous system is flowing, it causes more calcium, so we get more cross bridges, we get more contraction. And something that's called a positive ionotropic agent increases contractility. So sometimes you've heard of epinephrine. that epinephrine that is that fight or flight, that can cause your stroke volume to be increased. We have a drug called Digitalis, which is a heart medication that is meant to help the contractility of the heart. Fun fact, Digitalis is actually foxglove. It's the medication is made from foxglove, which is all over the Pacific Northwest. So for those of them who are saying, oh, natural medicine, blah, 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 I hate to beg to differ, but a lot of the drugs wouldn't exist out there if it wasn't for herbs in nature. So to them. So Digitalis,
I have
what?
a question about that. So
Yep.
that's what Digitalis is. It's basically like an epinephrine booster, or
It basically it increases contractility of heart, so it makes the heart have a stronger contraction, and it also helps the heart rate beat faster. Yes, you are correct on that. Which is why it's a low dose herb. If we were ever, I mean, I won't touch it with a 10-foot pole because it's too scary. But sometimes people will think that if they're not good at herb identifying, they think they're picking dandelion leaves and they pick up foxglove leaves. That's going to definitely mess up their heart rate. So FYI, if you see a plant that looks like it has dandelion leaves but has purple flowers, that is Digitalis. That is not dandelion, but don't go wildcrafting if you don't know what you're getting. Okay, and there are things that also that are called negative inotropic agents, which means that they can cause the opposite. So calcium channel blockers actually slow down the heart rate because they're slowing the amount of calcium that comes into the heart. Something called acidosis. We'll learn way too much about that in kidneys, and you guys will hate that chapter. I'm going to warn you, but I promise you it's important to know. And then sometimes people are taking potassium, and that helps also slow down your heart rate. And I know it's super morbid, but if anyone's heard of getting a potassium drip for the death penalty, that's what they're doing. They're giving enough potassium that the heart is just slowing down to a point where it can't function anymore. Okay. And then there's other things that regulate the heart rate. We have chemicals like hormones. So epinephrine is an example of one. Your thyroid hormone, thyroxine, is really important. Your thyroid hangs out here. We'll discuss that in a few weeks it's like my favorite gland in the world. But thyroxine increases the heart rate. It enhances the effects of the other things like epinephrine and norepinephrine. So its job as a hormone is to help increase heart rate for the purpose of the heart only. And then things like calcium, potassium, as I said, potassium is very dangerous. It can cause heart to stop. And calcium, the same thing. Too much calcium in the diet is dangerous for heartbeat. So you might see these terms thrown around on a chart on your patient. One is hypocalcemia, which means there's too little calcium. It's going to depress the heart. It's not going to make it sad because it's not working, but it'll make it stop working. Hypercalcemia, we'll see that sometimes when people either take too much vitamin D or their parathyroid hormone. If we remember that from the bones, that's not working well. We'll have increased heart rate and contractility, which can cause arrhythmias and death. Hyperkalemia is too much potassium. That can mess up the electrical systems. And then same thing, hypokalemia can cause arrhythmias. A lot of times if people have massive diarrhea that is like watery for days on end and won't stop, their potassium levels will drop, and they don't actually have issues from the diarrhea. They have issues because there's so little potassium that the heartbeat can't keep up. Okay. Other things that determine our heart rate, as I said, age. As we get older, yay, turning that magical numbers. As we get older, our heart rate goes slower. Females tend to have a faster heart rate than males. Exercise, we want to get our heart to beat faster because we're trying to train ourselves to be able at rest to be more efficient. And then body temperature. So a lot of times when a person has a fever, their body, in order to help that fever out, the heart rate needs to increase because that's what's going to make the warmth. And that's how the body temperature raises. Okay, there's some terms that that I want you guys to know. One is tachycardia, which means too fast. You might see that on your chart as a dental hygienist. Bradycardia means too slow. So yes, I said normal heart rate is between 60 and 90. In my opinion, I give that leeway of people having anxiety in my office because they're talking about stuff they really don't want to talk about sometimes. So there might be a little anxiety component, but technically anything that's over 100 beats per minute is a true tachycardia. Under 60 beats per minute is a bradycardia, which means that your heart's just not pumping things around. And then we have a condition called congestive heart failure. Normally that can happen from many things. Typical Americans, it's because of diet, exercise, poor health, but there are also congenital reasons. And then the coronary the atherosclerosis, which is a fancy term for cholesterol buildup in your vessels, that's what can also be an issue. Things for congestive heart failure, high blood pressure. Why we are trying to manage people's blood pressure so diligently is because the more that blood pressure is higher, is the more likely that heart's going to have to work harder and fail at what it's going to do. Then we have the multiple myocardial infarctions. So if too many heart attacks occur and they survived it, their heart's just not going to be working as well. So they're going to have buildup of things. And there's a couple of things called dilated cardiomyopathies. A lot of these are either born with, but sometimes certain drugs that are given for like chemotherapy can actually cause this issue. And these are all reasons to make sure that if anyone has them from a doctor standpoint, that we manage them really well because, well, we want people to live their lives. So congenital heart defects, I kind of talked a little bit about that before. Congenital heart defects, sometimes there's a hole in that ventricular septum. So remember, we don't want that. That means mixing of blood. We don't want oxygenated, we don't want partially oxygenated blood getting out to our tissues because that's dangerous. Sometimes this aorta, there's a little band here in utero that is meant to pinch it off because you don't really, not pinch it off, but kind of just make it not work as efficiently because there's a little connector tube that connects everything together. So you can bypass the lungs. But sometimes when this heals back up, this gets too narrow after birth and that causes issues. And then we have the tetralogy of Fallot. So you can see here, hole here, really small over here, really small over there. Not good. Okay, so that's it for the heart itself. We're gonna take a break here and we'll meet back up at 10, what time is it? At 10:23, if that's okay. I know it's a strange time, but I was expecting to have this end on the 10:20, but that did not happen. So 10:23, I'll see you guys soon. I'll stay on. You'll see me drinking my coffee. All right.
We'll go over another hour.
Yeah, the class is technically until 11. So yep, there's another one.
Okay, thank you.
Can I ask you some questions, Dr. Wood?
Sure.
So I know that I've experienced like pounding heart sometimes if I'm not even like exercising. Maybe I'm like drinking like coffee or alcohol or like things like that. Is there like a dangerous like level of like heart rate?
I would actually, and I hate to do this to Michelle's asking that question, right? That sounds like
yes.
Okay, sorry. So I actually have to say for legality reasons, I need to pause my recording.
Recording, okay.
Oh no, was this? Yeah, it's paused because no one needs to hear all that about naturopathic medicine. Yes, hashtag I love it, but you know, that's that. Okay, so now we're gonna talk about the vessels. We talked about the heart, and that took like a long time to talk about. The last hour is gonna be dedicated to, and is everyone there, guys? I see black screens, but I'm assuming y'all are there.
I'm here.
Yes, we are here.
All right, cool, we're all there. Totally okay, as long as I see your name rolling at this point. So vessels, we need to know the differences between the different types of vessels. So the key terms here, bolded, which means you need to know. So blood vessels, they're the pipes of our body. They're the ones that are bringing blood to and from where it needs to go. Arteries carry blood away from the heart, except for and they're oxygenated except for, there's two circumstances. So one is the pulmonary artery. It's taking blood away from the heart to the lungs, so it has no oxygen in it yet. And then, sorry, my cat just decided to claw me. And then we have in pulmonary circulation, we'll learn about that later on, but there's some vessels in the fetus that don't have oxygen in them. We have capillaries, which are tiny little, sometimes people might say, oh, I can see my capillaries on my skin. Capillaries are really, really tiny vessels that come in direct contact with tissue. So the arteries are not actually the direct suppliers of blood to our body, it's the capillaries. Capillaries are really tiny. They're normally single cell thick and they allow for diffusion of gas and nutrients. Then we have veins, and the veins carry blood towards the heart. They're deoxygenated, so blue blood, except for that one little pulmonary vein, which is brought from the lung. Oh, hold on one second. My cat is biting. Seriously? Sorry, guys. Hold on one second. My husband locked my cat in my room with me. Hold on one second. Okay, fingers out. Fingers, one. All right. Well, if my cat bites me, it was nice knowing you. He clearly has a vendetta against me. Okay. So, and then we have the veins, as I talked about right there. Okay, so right here is our little schematic here. So heart, we tend to look at it as a box shape. So a lot of times for study purposes, it's best to actually draw it as a box. That way you just understand there's 4 chambers. There's not 5, there's not 3. We're not cows and we're not frogs. We have 4 chambers. We have different types of arteries. We have elastic arteries, which is normally like that aortic arch that we saw come off of the heart. And that elastic artery, when something has elastic in it, it means it has the ability to expand. And if we have a high pressure system sending a ton of blood out, we need these arteries to be able to expand to get the blood to the rest of the areas. Okay, then we have muscular arteries, and these are known as distributing arteries, which means that they're going to major organs, but they haven't quite fully branched out to everywhere. And then we have arterioles, which are the smaller versions of the arteries, and they are actually what a lot of times work on. They don't have a ton of muscle in there, but they work with resistance. So the higher the resistance something else is, the more pressure that is. And then these arterioles become into this capillary bed, and that's where everything happens. That's where the mishmash of getting oxygen, nutrients, all that B12 that vegetarians are taking, blah, blah, they get exchanged right here. And then they come out as venules. And the venules then become small veins, which basically just accept blood. And then we have large veins, which are larger to accept the rest. The main differences here is that veins, especially in the lower legs, have something called valves. And those valves are prevent backflow. So sometimes we might see people who have like little purple lines on their legs. Those are called spider veins. It's because those valves have become incompetent and stopped working. And the backflow, that blood is not able to get back up to the heart. It's very minimal. It's normally just cosmetic. It's not a ton of blood in there that's stuck. It just looks bad. But that's because those valves stop working and it's not able to get the blood back up to where it needs to get to. And it kind of just pooled there. And then we learned last week about lymphatics. Lymphatics work really closely with this capillary system and make sure that we're exchanging out the fluid that's in the blood to keep things clean, filtered. Okay, arteries and veins have very similar makeups. They have 3 different layers to them. They have the tunica intima, which is the innermost layer. This is the endothelium that we learned about in the beginning. And then so that's the part that has contact to the actual blood. So when we're talking about cholesterol deposits, as far as heart attacks, that's where the cholesterol deposits are going to hook up to. They're going to hook up to this endothelium, cause some damage, and then inflammation occurs. And that's actually what the big problem is. We have the tunica media, which is the muscle. It's smooth muscle. We have no control over it. So tunica media is the second layer. In the artery, the tunica media is much thicker than in the vein because the arteries need to have more of an important job to do to get blood out, more pressure. I mean, they're both important, but veins don't really need to, they have other ways to get blood out, and they don't need that much of a muscle. And the outer layer is called the tunica externa, okay? The capillary system is literally just these endothelial cells, and depending where you are in the body, they'll look different. And there's a basement membrane, and that's all there is. It's a single layer thick, and that's it. And they come together. We have things called anastomoses that basically they're happening in your brain, in your liver, and in your areas of your gut. Basically, anastomoses, instead of having just one pathway to something, there's multiple pathways to it. So in the brain, we have something called the circle of Willis, and that is an anastomoses to send blood to the rest of your brain. If one of those gets blocked, it's okay because it can go around a different way to get around, depending on where it is. But if we didn't have those anastomoses, that vessel is blocked, the person would have a stroke. End of story. So that's the purpose of anastomoses there. Okay, we have the 3 different types of arteries. As I said, we have elastic arteries, muscular arteries, and arterioles. Elastic arteries, they're thick-walled, they have low resistance. As I said, their idea is just to act as pressure reservoirs, and their ability to kind of elastic, so stretch and accommodate. So it allows for even amount of blood flow to be happening. So that's why the aorta is so big. It's elastic artery. It's allowing for an even blood flow to come out. It's not like I'm getting 20 liters here, now I'm getting 2 liters here. It's the same all the time. Okay, muscular. Oh, Jesus Christ. Sorry. Oh, sorry, guys. Binger, stop. Sorry, guys. That was my cat giving a real good nip. Okay. So muscular arteries, they have a really thick tunic media because that's where all the muscle is. These cause vasoconstriction. When we're talking about vasoconstriction, we're talking about heartbeat. We're talking about basically anywhere in a vessel that you're going to have. So we're talking about heartbeat. We're talking about reducing blood flow. We're talking about increasing pressure. Those are things we want to be thinking about. Now, arterioles are very small, the smallest of the arteries, and these are the segues to our capillaries. And these have the most resistance because if you think about it, the larger the diameter, the less resistance it's going to have to flow through. The smaller you get, the more resistance, which means the more pressure against it is going to be happening. So we have 3 different kinds of capillaries. We have this continuous capillary right here. These are the ones that are in the skin, the muscles, the lungs, the central nervous system. They have what's called, you don't have to know this whole, just this, but no, there's no holes. Okay, they're the least permeable and most common. So there's not, they don't allow as much stuff in. We have fenestrated capillaries, which we'll see mainly in the small intestine and in the kidneys. And they have tiny little holes, and it's because they have to have more room to allow for more exchange. And then we have sinusoid capillaries, which you'll find in liver, bone marrow, spleen, and adrenal medulla. And that's because we need a lot more things to be traveling through there. There's lots more proteins. There's a lot more waste that needs to come through. Okay, and this is what the typical capillary bed looks like. It is an arteriole, remember, most resistance, leading to the terminal arteriole. So we're breaking down some of that resistance. And then we work on diffusion here. So diffusion is what's occurring at the capillary aspects. So veins, we carry blood towards the heart. They become venules, and they are the smaller aspects. They have endothelium, just like everything else. They're very porous, and remember, they have valves, okay? So valves are meant to prevent backflow. And there's something called capacitance vessels, which means they act as blood reservoirs. So they're big because if we can't get enough blood to somewhere, they act up to help keep it. So in the brain, we have some of these little sinus areas that act as blood reservoirs. In our legs, we have some of them. It's meant to, if we don't have enough blood, we can take some out of here and get it out. If we were looking at a microscope, I actually have one of these where it looks like a Cheshire cat. It's kind of cool. But you can see the differences between the artery and the veins. So the veins, you see the difference here? This purple is that endothelium, and that it has a special stain on here. So you don't see a lot of that muscular wall right here. You just see this tiny little thing right here. The arteries have this giant tunica media, which is the muscular wall, and they're much thicker. And you can see if you do a cross section, veins tend to push in on themselves. Arteries tend to stay nice and wide open. Okay, so I already talked about the valves. They prevent backflow. They're most important in the limbs, so that's why we see those spider veins. We also have venous sinuses, and their idea is that they are thin-walled and they act as reservoirs. We already talked a little bit about varicose veins. So they're mainly for they're not dangerous. They're just annoying. They look yucky. They're spider veins. They're painful sometimes because things can build up. The only issue that becomes an issue with varicose veins is when they get too inflamed and they cause clots. But when people work on their feet all the time, typically recommend wearing compression stockings because that helps the muscular pump bring the blood back to the heart and not just pull at the legs. Pregnancy and obesity are major reasons for why we see these varicose veins occurring. Talked about the anastomoses, but they're super important. It's kind of like going on the highway. If there's road work being done, you don't want to have to just sit there in traffic and wait until that road work stops. You want to be able to go around the detour and get to where you got to go to. So they're common. The joints, also our knee joints, all of our joints have anastomoses because we need blood to flow to them constantly. Abdominal organs, brain, heart, kidney, and spleen. Okay, those are the most common places for anastomoses. So we talked a little bit about blood pressure. We're going to expand on it a little bit more. So we have blood flow, which means the amount of blood that's flowing through the vessel. We have blood pressure, which is the amount of pressure. So we measure that in millimeters of mercury. And that's how much pressure is being put in. And resistance is how much are we stopping it from flowing. And resistance is important when we're determining blood pressure, because there's that mainly is the main determinant of blood pressure is resistance. And there's three things that affect it. There's blood viscosity, which means how thick the blood is. If it's really thick, then it's not going to be able, it's going to affect its resistance. The blood vessel length. So we were talking about the tall persons versus short person. That total vessel length has a big difference about how much resistance is present. And then how big that vessel is. If the vessel is bigger, there's going to be less resistance because it's not going to oppose the flow as much. So an example is, ooh, I want a milkshake every time I look at the slide, sorry. So milkshake, we're thinking about it, if you're trying to slurp that milkshake through a small straw, it's going to take slower, it's going to take more effort because there's resistance. Bigger straw, you're going to get that all in one fall swoop like your McFlurries, okay? And then for pressure, you don't have to memorize this equation, but I want you to, some people just like to see the equation, so I put it out there. So blood flow is basically the change in pressure times divided by resistance. And it's all about the pressure. So if you see a question about blood pressure, you can safely assume by process elimination, there's going to be something about pressure in the answer. So the most important thing for pressure is that the resistance is what's happening when flow is opposed by the resistance. It's causing pressure, okay? When we have sudden drops in the pressure, that's not good. And we have sudden increase of pressure, it's not good. But this is a little graph to show us the differences in pressure. So we can see here aorta, which is the main vessel that comes off your heart, is the highest pressure. As we go down to arteries and arterioles, the pressure decreases. Veins have low pressure. Okay. Then we have the actual blood pressure. When we're measuring the blood pressure, we're measuring the arterial blood pressure, not the venous blood pressure, because the venous blood pressure doesn't really do much for us. And it's determined by the elasticity, so the abilities of the arteries close to the heart to expand. So the aorta is playing a huge role in your blood pressure, and then how much blood is actually there. Then blood pressure near the heart is pulsatile, which means that with each heartbeat, it has a change of pressure. We talked about systolic versus diastolic, so I'm not going to go that much into detail here. The pulse that we feel is actually our blood pressure. It's the throbbing of the arteries due to the differences in the systolic and diastolic pressure, and that's why we feel a heartbeat. You could hear it up here in your neck. If you go between your trachea and your sternocleidomastoid, you can feel something pulse against you. You could feel what's called the radial pulse, which is underneath your thumb. This is called the thenar eminence. You go underneath there and you could feel your pulse beat against. Some people have really deep pulses, so don't freak out and think you're a vampire if you cannot feel it. Some people have really deep pulses or some people have really shallow pulses. So you just have to play around with the amount of pressure your fingers are putting on to feel that throbbing. And what we're really measuring during blood pressure is mean arterial blood pressure, which means the average of the blood pressure. I don't want to know about every minute. I want to know on average what's their blood pressure. And how do we kind of tell how these things are affecting? How do we tell our circulatory system is doing its job? We take vitals. They're vitals because they're vital to our existence. So we take a pulse. As I said, you could do a radial pulse. In kids, fun fact, they don't really have a strong radial pulse, so you have to use their brachial artery. So typically under 7, I'll feel for over here. The femoral arteries, which are in your groin area, I'm not going to stand up and do that to you guys, but in your groin area, you could feel a pulse from there. You could feel a pulse behind your knee. You can feel a pulse under that medial malleolus, which is the little bump on your ankle. Just behind that, you'll feel a pulse. And then the dorsalis pedis, which is the artery of your foot. If someone's diabetic, we always check that we feel those pulses, because if we don't, we start thinking there's some damage being done. And this man here is showing us where all the pulses are. The main important ones that we use clinically are the carotid, which is that neck one, the radial, and then for children, especially when they're newborns, if I'm trying to figure out if they have a congenital heart defect because I don't have x-ray vision, I feel for their femoral pulses. If their femoral pulses are uneven, then that's a clue to me that something's not right with their cardiac system and they're being sent to a cardiologist. And how do we measure it? It's a fancy blood pressure name for a blood pressure cuff is a fancy thing called a sphygmomanometer. I can't even pronounce it half the time. And what are we measuring? It's called Korsakoff sounds. So we're actually listening with our stethoscope. We're listening when we take the blood pressure, we're pumping up all the way till 200. And then we're listening for when we start emptying, we're listening for that pulse to keep happening because that blood pressure is causing a pressure that stops the pulse for a moment. We're releasing that pressure. And when we hear that first sound, that's your systolic. And then when you don't hear it anymore, so you're letting the pressure out of the cuff, that's your diastolic. So as I said, 120 over 80, there's different, every year, something called the JNC comes out with guidelines. The current guidelines are stating that JNC is for at least for the 8 that I go for is 120 is over 80 is normal, 90 over 60 is hypotension, above 140 over 90 is hypertension. Capillary blood pressure is a lot less there. Venous blood pressure, we already discussed, a lot less there, okay? How do we get blood back to the body if there's not as much pressure? There's different things that occur. We have a muscular pump. So our skeletal muscles literally go like this, pump, 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 and milk the blood back towards our heart. And the valves prevent the backflow. Our respiratory pump, which is our breathing, actually works as a way for the thoracic cage. So when we're breathing in and out, our lungs are actually helping to pump the blood back in. And then sympathetic nervous system, vasoconstriction, that is helping making it smaller. So it's going to go back up. Here's a picture of that muscular pump. We have a few ways that we monitor blood pressure. We have short-term regulation, which is through neural controls. We have another way of short-term, which is hormonal controls. And then long-term, if we're thinking about long-term blood pressure control, you guys are thinking kidneys, renal. So mean arterial blood pressure, the reason why I want you to understand cardiac output is because cardiac output plus the total resistance, peripheral resistance around the body is what makes up your mean arterial blood pressure. This is a great study thing here because these are all the determinants. If we change stroke volume, we change the diameter of blood vessel, we change blood viscosity, everything down the road gets changed, and that affects your blood pressure. We have a couple of areas that respond to pressure changes. They're in the carotid sinus up here, which is why when people are taking pulse, we don't say don't do it at the same time because it can affect your blood pressure or make you pass out. Baroreceptors respond to the amount of pressure that they sense, and they send messages to your brain. We have the medulla itself, that is the cardiovascular receptor. There's chemical receptors, and there's higher brain centers. Epinephrine and norepinephrine are our short-term heart rate and blood pressure controllers. We have angiotensin II, which we'll learn more about in kidneys, which is really important for vasoconstriction. Antidiuretic hormone, we'll learn more about that in a few weeks. And then something called atrial natriuretic peptide, which helps decrease their blood pressure. So epinephrine, angiotensin, ADH all help increase your blood pressure. Atrial natriuretic peptide, ANP, helps decrease your blood pressure. And then here we can see what happens when, so body really responds to low blood pressure. So low blood pressure is being sensed. What's happening is that you're getting a little stimulation here. So decreasing arterial pressure, the baroreceptors in your carotid or in your rest of your body are sensing this. Your sympathetic nervous system fires up and kicks on. You have then a signal from your kidney called renin. It's a hormone. Renin gets secreted from your kidney. It causes a bunch of other hormones known as angiotensins to kind of be converted. And this here, angiotensin 1 to angiotensin 2, uses something called angiotensin converting enzyme. That is the major blood pressure medication that people are on. It's called ACE inhibitors. If someone has high blood pressure, they're going to use an ACE inhibitor to prevent this high blood pressure from happening. So those are things like lisinopril you might see. So the angiotensin gets converted to make the blood pressure go up to angiotensin 2, and then does a few other things. It goes to the adrenal cortex. Adrenal cortex secretes something called aldosterone. Aldosterone increases sodium reabsorption, which sodium, remember, water follows sodium, makes your blood pressure higher. We have something called the antidiuretic hormone, which is coming from the posterior pituitary, where water gets uptaken to the blood. The hypothalamus then tells you if this is happening, let's drink more water, because that's another way we can get our blood pressure to go up, is drink more water. And then we also have vasoconstriction, which is increasing total peripheral resistance, and then we get our increase in blood pressure. You guys are going to look at this at your own leisure. It is important that you understand this. This is going to come back on many quizzes because it's important for respiratory, important for when we get to hormones, and important when we get to kidneys. So you might as well learn it now. Okay, so summary. Goal of blood pressure regulation is to keep the blood pressure high enough to do what it needs to do to perfuse it, but low enough not to burst out anything. This is it again, in case you need it. And this is now adding everything else, including the cardiac output, total resistance, how everything works together. This slide is really good for studying. Some people have heard of the term shock. And shock means that there isn't enough blood. Sometimes it means that there's not enough blood volume. So there's been blood loss. So your body goes into shock. It doesn't know what to do. There's vascular shock. So sometimes this happens because something has caused your body to vasodilate and the resistance is there. So you can't maintain your blood pressure. Vascular shock tends to happen or during anaphylaxis or extreme allergic reactions. And there's cardiogenic shock where the heart itself can't work. So it causes shock. Blood flow is important because the whole idea of blood flow is that we need the blood to flow at a speed that allows for tissue perfusion, which means that tissue perfusion means that enough oxygen is getting to the blood. So oxygen is occurring either where it's at the tissue level, gas exchange in the lungs, digestive tract. You need tissue perfusion so you can get nutrients absorbed, and we need tissue perfusion to have our kidneys to make urine. And it's all about who controls it. So extrinsic control of having how much blood flow is done from our sympathetic nervous system. Intrinsic is a local control. So there's something called autoregulation, and it happens at that area that it's occurring. So that a lot of times means that the little arterioles that are in the area sense that something's not getting enough oxygen, and it makes changes to increase or decrease their diameter depending on what they need. And yes, hashtag exercise is super important. It's good for mental health, good for physical health. At rest, your muscles get about 20% of total blood volume. That's still a ton. That means compared to everything else. But during exercise, we get skeletal muscle gets about 70% of the blood flow. And our muscles have ways that it also works with the sympathetic nervous system and hormones to get that to come together. So here's our autoregulation on intrinsic, what's on the inside, what we control. This is whether metabolic issues or not metabolic issues. And then we have extrinsic controls, which is those hormones, that mean arterial pressure, the kidneys, everything that we talked about that has control on these vasodilating or vasoconstricting, depending on what we need our blood flow to do. Velocity, how fast it's going, also contributes to how well our tissues get perfused. So if our tissues are not getting a ton of speed, then depending on how we change the speed, if we make it faster, there's not going to be enough time actually for enough gas exchange. So sometimes we slow it down to allow more things to either diffuse, or we need more stuff depending on what we need, and we quicken it up to get more of the nutrients into the blood that we can. And then the key term here is that diffusion. Diffusion is what's going to happen to the capillaries. That's the only thing that's happening at the capillaries for their exchanges. We have two different types of pressure that are in the capillaries or in the arterioles that we need to understand. And these are important to understand. When people have things called edema, that means that fluid that was supposed to be inside their vessels are going outside their vessels. And sometimes we see swollen feet, sometimes we see swollen hands. There's two different types of pressure here that we need to know about. One is hydrostatic pressure and one's colloid osmotic pressure. So hydrostatic pressure is the force that's exerted by the fluid pressing against the wall. So this is the pressure going out to the vessels, okay? And then don't worry about the capillary versus interstitial, but understand the hydrostatic pressure is the force that's pushed against the vessels itself. We then have colloid pressure. Colloid osmotic pressure is due to all the different types of protein that's in our blood, and that's the pressure that's coming back in it's being pushed against the vessels, almost like a sucking type of way, putting it towards the plasma proteins and pulling the water back in. So we need a balance for homeostasis to do this colloid osmotic pressure and the hydrostatic pressure to keep the capillaries happy and not to have tissue leakage outside of the vessels. So that's basically what I said here. We need to keep it even, Steven. Hydrostatic and osmotic pressure should be even for the most part. This is just showing an example of what happens when we have blood flow here. It's just showing for those who do better with visual here. Edema, we talked about that. So edema can happen for different reasons. Either the hydrostatic pressure has increased, and maybe it's because we lost fluid, lost some blood, or we have colloid pressure that has increased and it's pushed, or we've lost some proteins and it's unable to keep that. So sometimes malnutrition or liver disease, people get edema or swelling of different areas because there's not enough protein to keep that colloid pressure going. So here's a fun picture of edema, because for those who like to see the grossness, this is very common in pregnant women. This is pitting edema. We measure how much edema is in a area by pressing our thumb on it. Depending on how long that indent lasts for, we grade it on a 1 to 4 scale. This person, I can't tell in person, but that's not even that horrible of edema. Okay. And why do we take blood from veins and not normally from arteries? We're not Lestat. We don't want an outpouring. If anyone knows Interview with the Vampire, we don't want outpouring of things. We need, it's a high pressure system. We need these things to stay. We need to get it from low blood pressure systems. Remember that the brain and digestive system have very unique venous draining systems. They actually have their entire thing called enterohepatic circulation. And we'll get into that in digestive. Okay, and then arteries run deep. Veins, we have superficial and deep, but arteries run deep because it protects it from the higher pressure. Okay, so this is just a schematic for those who like to do box diagrams, a little bit more of what we spoke about. These are the major arteries that you guys are responsible for knowing about. This will be on your lab as a fill-in. And these are the major veins. I'm not going to go into them because I feel like you guys can look at a diagram. The ones that are the most important are the ones that I want you to know about, is to understand the 3 branches of the aortic valve, not aortic valve, so aortic arch. Know the brachial artery, the axillary artery. Definitely know that it's a femoral artery. And then the femoral artery breaks off into the anterior tibial artery and posterior tibial. Anything on this diagram would be fair game to ask you guys about. Same thing for this. Anything on this diagram will be fair game to ask you about. A question that I might ask you about is, which one of these veins supply the arm or bring blood back from the arm? Which one of these arteries supply blood flow to the foot? And I would give you guys a choice on that. Okay, that's it for the lecture. We're about done at 11 o'clock. And then pop quiz, hot shots. You guys have a pop quiz still out there? Everyone? Yeah. Okay, here's your chance to earn 5 extra bonus points. Hold on, I'm gonna stop my share. Oh wait, stop my share and then